Hello, everyone. My name is Dr. Michael Mamone. I am a second-year internal medicine resident with the Florida Atlantic University. I'll be presenting a case of Clostridium difficile bacteremia in a patient with multiple comorbidities and risk factors. My co-authors are Andrew Wang, MS3, Dr. Stephanie Corey, Dr. Jonathan Coelho, and Dr. Daniel Gutman. A little bit of background on the case. So C. diff is a gram-positive anaerobic bacterium. It's a common cause of nosocomial diarrhea and colitis. However, there are some extracolonic manifestations associated with C. diff, and patients who suffer extracolonic manifestations are those who have relatively poor outcomes and can be seen with bacteremia. So for the case, this is a 72-year-old male. He has a past medical history of COPD, coronary artery disease, colon cancer, post-colectomy with ileostomy, who initially presented to the emergency department with the chief complaint of rectal bleeding. He was admitted and being worked up for that. However, during his hospital course, he became hypoxic and developed an acute abdomen, was brought emergently to the OR for an emergent expiratory laparotomy. During the procedure, they found a perforated colon with fecal peritonitis. He underwent the appropriate surgical management. Following surgery, he was managed with Zosyn and diflucan for the perforation. However, he had persistent fevers and was having worsening vasopressor requirements. Blood cultures were drawn and were positive for C. diff, which was confirmed with the microbiology lab. CT abdomen showed numerous intra-abdominal abscesses, as seen in Figure 1. He underwent numerous IR-guided drainage of the abscesses throughout his hospital course and had various cultures drawn from the abscesses, which grew multi-drug resistant Enterococcus faecalis, Pseudomonas, as well as C. diff isolated in one of the cultures. The patient received 3 weeks of IV Avacaz, Flagyl, and vancomycin with 10 days of PO vancomycin therapy. At the end of his treatment course, he underwent a repeat CT scan, which showed complete resolution of his numerous intra-abdominal abscesses, and then repeat blood cultures were also negative. So for our imaging studies, looking at Figure 1, you'll see a CT abdomen revealing numerous intra-abdominal abscesses. You have a very large one up in the splenic area, one peri-gallbladder, as well as numerous seen throughout the colon. And then our Figure 2, you'll identify that there are no fluid collections seen, showing appropriate course treatment. So for our discussion, C. diff bacteremia is an extracolonic manifestation of C. difficile colonic infections. Only about 1% of C. diff infections actually have extracolonic manifestation, whether it be empyema, possible osteo, abscess formation, also pericarditis. There's only actually about 137 cases that have been reported in the last 50 years. However, given that there's an increased incidence of nosocomial C. diff, this may cause a further increase in the prevalence of C. diff bacteremia. And those who actually are found to have C. diff bacteremia have poor outcomes with a high mortality rate of 20 to 53%. One of the major teaching points of this case is kind of identifying those who are at risk of developing C. diff bacteremia, and those are those with immunosuppression, inflammatory bowel disease, some form of underlying malignancy, and surgical manipulation of the colon. Our patient had a form of malignancy as well as surgical manipulation of the colon during his hospital course. Those found to have C. diff bacteremia are typically found to be in septic shock, history of recurrent antibiotic use, have a prolonged hospital stay, and recent surgical procedure. Once again, these were all seen in our patient. Now, management, which is another important teaching concept, typically requires both surgical intervention and medical therapy. There's no current guidelines for management of C. diff bacteremia, as they're typically polymicrobial and overall incidence is pretty rare, but should be managed with IV therapy with either vanco or metronidazole, as well as concurrent PO vancomycin for the intracolonic C. diff. So in conclusion, C. diff bacteremia is a rare complication of C. diff colonization. Although this is rare, increased incidences most likely will be occurring over the next several years due to increased incidence of C. diff intracolonic because of nosocomial infections. It is very important for providers to identify those at risk, as well as initiating early treatment with IV therapy with concurrent PO therapy, as there are poor mortality in these patients. Thank you for listening to my presentation. I hope you have a great day.